Welcome to the FAST exam. My name's Matt Lyon. Let's begin. So what does FAST exam stand for? FAST means Focused Assessment in the Trauma Exam. The role of the FAST exam is to rapidly diagnose free intra-abdominal fluid. In the trauma patient, we assume this free fluid to be blood. This may or may not be the case, as we'll see later. This is also part of the secondary survey in ATLS. Clinicians who use ultrasound in their daily practice can use the FAST exam not only for trauma, but for many other indications. However, we will focus on the trauma applications in this lecture. So why do we want to use the FAST when we have many diagnostic modalities in the trauma patient? Well, in the trauma patient, every minute counts. This is why we call it the first hour the golden hour. If we can make diagnoses quickly, we can have an impact on morbidity and mortality after trauma. There are many diagnostic options, however. Physical exam is the initial one we often choose. However, it is insensitive and often misleading. Diagnostic peritoneal lavage gives similar information to the FAST exam in diagnosing free intra-abdominal bleeding. However, it is an invasive test and does have some morbidity and mortality. Computed tomography is an excellent choice. It does give you very specific diagnoses of what's going on in the trauma patient. However, it does require the patient leave the monitor environment of the trauma room. Ultrasound, in contrast, is done at the bedside, so it is not necessary to leave the trauma bay. It's as sensitive as DPL in diagnosing free fluid, but it's non-invasive. It's also rapid, can be done in less than a minute, and can be done in conjunction with other resuscitation or other diagnostic tests. Further, it's repeatable, so if the patient's condition changes, the patient becomes hypotensive, you can repeat it to see if the patient now has free abdominal fluid or bleeding into their abdomen. The clinical indications for the FAST exam are blunt trauma, penetrating trauma, and possibly the patient with altered mental status that you think may have had some trauma. But the best indication for this exam is the blunt hypotensive trauma patient. Here, if you find intra-abdominal bleeding in a trauma patient after blunt trauma and they're hypotensive, they don't need any other further testing. They can go straight to the laparotomy. Therefore, you have bypassed CT and you have sped their diagnosis and you've gotten them quicker to surgery. Therefore, you should have a better outcome. For machine setup, there are several probes that you can use for the FAST exam: the curvilinear abdominal probe and the phased array cardiac probe. The curvilinear abdominal probe is a low-frequency probe. It's generally used for all abdominal imaging. It gives very good resolution, very good detail. It does not, however, give very good images of the heart. The phased array or cardiac probe is sometimes the only probe found on a machine. This probe not only images the heart well, but can image the abdomen. The disadvantage is that it has a small footprint, so you have to move the probe a fair amount in the abdomen to get all of the views you need to get. Either of these probes will work. I personally recommend the curvilinear abdominal probe unless you're specifically looking at the heart. So the FAST exam is a protocol ultrasound exam. That means it has specific views that must be obtained and specific organs that must be imaged in those views. The first view is the right upper quadrant window. In this view, we're going to image the hepatorenal recess. This is also called Morrison's pouch. This is the most likely place for blood to collect in the supine patient. We're also going to look at the right hemithorax to diagnose blood into the chest, or hemothorax. And we're going to look at the right paracolic gutter. The right paracolic gutter is a potential space where blood may collect inferior to the kidney. However, this is not a common place. Morrison's pouch is the most common place for blood to collect. To perform the right upper quadrant view, we place the probe in the flank, generally in the anterior to mid-axillary line, with the probe up and down the body, as you can see in the picture. We're going to try and visualize the liver first. The liver is the largest abdominal organ. It's generally easy to see. When we image the liver, we can orient ourselves. The bright hyperechoic line at about the 7 o'clock position to the left of the liver is the diaphragm. Towards the right is the kidney. The kidney is hypoechoic compared to the liver with a hyperechoic center. The space between the two, the liver and the kidney, is a very bright line. This is Morrison's pouch. This is where we look for blood accumulating. We look above the diaphragm, and this is the hemithorax, or this is into the chest cavity. Notice that it is fairly bright. This is a mirror artifact of the liver, so it should look somewhat like the liver. Fluid would be black. The paracolic gutter is at the inferior pole of the kidney, and we'll see an example of that in just a minute. The next view is the subxiphoid window. Here we're looking at the heart, particularly at the pericardium, and we're looking for a pericardial effusion. We're also going to look at the IVC. The IVC helps us with resuscitation. To image the subxiphoid view, We place the probe under the xiphoid. The probe is generally horizontal and directed up underneath the ribs towards the heart through the liver. Here in the lower image we can see the liver at the top part of the screen, and then we see the 4 chambers of the heart. We know that the right side of the heart is next to the liver, so it's right ventricle, right atrium, and then further down the screen is left ventricle and left atrium. The pericardium is the bright white line that's opposed to the epicardium, and we cannot distinguish the difference between the pericardium and the epicardium. If there were fluid, these would separate, and the fluid would be seen as a black line separating the 2 bright white lines. To obtain the IVC, we rotate our probe north-south, up and down the body, and look posterior towards the spine. And we see the IVC is this thin black line, could be a thick black line, this running posterior to the liver into the right atrium of the heart. The IVC dilates and collapses with respirations, and we can use this to gauge the central venous pressure. The next critical view is the left upper quadrant window. Here we're looking for the splenorenal recess, the left hemithorax, and the left paracolic gutter. This is very similar to the right upper quadrant view. The difference is in the left upper quadrant view, your probe will be further back towards the bed. So place your probe in the left upper quadrant. I generally place my hand on the bed and angle up slightly. The spleen is much smaller, so it is more difficult to find, but once you find the spleen, it looks very similar to the liver. The diaphragm at the 7 o'clock position is a hyperechoic line, the kidney inferiorly, and we see the spine deep on the screen. The last window is the pelvic window. Here we're going to look for the bladder. We're going to look for fluid around the bladder. You will notice the uterus and vagina in a female and the prostate and seminal vesicles in a male. These can be a little challenging at times, but knowing these normal structures helps you differentiate free fluid from normal structures. For the pelvis, we place the probe across the body. Generally just above the pubis bone is where you have the best view of the bladder. The bladder, when it's full, looks like a trapezoid in short axis. As we rotate the long axis, it looks like a triangle. Posterior to the bladder will be the vagina or the prostate. If you angle up more into the belly, you'll run into the uterus in a female. So here's our fast end sequence. We're in the right upper quadrant, and we see the liver and we see the kidney. Panning all the way through the space looking for a hypoechoic or black stripe of fluid. Cardiac, we're using a cardiac probe, we're going through the liver, we see the 4 chambers of the heart. We see that the heart is pressed right up against the diaphragm, so there's no pericardial effusion. The left upper quadrant, we see the spleen, much smaller than the liver, and the kidney, and the diaphragm. And in the pelvis, we see the bladder. We see bowel surrounding the bladder. As we tilt down, we can see the rectum. We can also see the prostate when we get just low enough in the seminal vesicles. One more time. This is the right upper quadrant. We see the liver. We're panning through Morrison's pouch. There's the kidney coming into view. There's a bright hyperechoic stripe between them and not a black hypoechoic stripe. Subcostal or subxiphoid, see the liver and the heart. Again, all the blood is contained in the heart and not in the pericardium. Left upper quadrant, we see the spleen, much smaller than the liver, kidney, diaphragm, spine. And the pelvis, we see the nice hypoechoic fluid-filled bladder. We see bowel surrounding it, but we do not see any free fluid anywhere in the picture. If we're going to add the IVC to this, we start out flat with our probe, we image the heart, we turn long axis, and then we slide over to the right. Here we see the liver and the IVC. This hypoechoic circle in the screen is the hepatic vein. It is difficult sometimes to know the difference between the IVC and the aorta. However, if you look for the liver and the hepatic vein, you know that this is the IVC. Then we look to see it's expanding, collapsing with the respirations. Sometimes it's a challenge to find the IVC if it's very small or flat. This one's very easy to see because it's nice and thick. So what is our goal in this exam? Our goal is to evaluate for free intra-abdominal fluid. All fluid looks black. We assume that it's blood in the trauma patient because that makes sense clinically, but all fluid is black. The picture on the left is Morrison's pouch, and we see the liver and the kidney, and we see a small black stripe highlighted by the red arrows. This is free fluid in the abdomen. There should not be fluid between the liver and the kidney. And the picture on the right, we see the spleen and the kidney, and we see a big hypoechoic stripe of fluid outside of the spleen highlighted by the red arrows. This is also free intra-abdominal fluid. It should not be fluid here. So how good is FAST exam for detecting free intra-abdominal fluid? This is a prospective study of the FAST exam in abdominal trauma. It had 2,963 patients with a sensitivity of 84% and a specificity of 96%. The overall accuracy was 96%. This is pretty good. But what was missed? The things you missed with the FAST exam were the retroperitoneal injuries, bowel injuries, and intraperitoneal solid organ injuries without hemoperitoneum. The thing is that the sensitivity and accuracy depend on several things. One is the amount of blood present. So the less blood there is, the harder it is to detect, the lower your sensitivity. The bleeding rate, because the amount of blood is dependent on how quick the artery is losing blood, and the time since injury. So if you look at the initial FAST exam in this study, initial FAST exam had a sensitivity of 31% and an accuracy of 92%. If you waited and repeated the exam, more blood will have collected, and so your sensitivity goes up. It goes to 71% and accuracy of 96.7%. So as we can see that multiple exams increase your sensitivity as well as specificity as well as your accuracy. So how much fluid can you reliably detect? Well, this was a cadaver experiment and they were only looking at the right upper quadrant, but the mean volume detected was 619 milliliters. So a small stripe of blood is a large amount of blood. So a small stripe of fluid on ultrasound is a large amount of blood. The sensitivity at 1 liter was 97%, but only 10% of physicians were able to detect less than 400 milliliters of blood. Again, the more blood there is, the easier it is to detect. So let's go back over the negatives of the FAST exam. You can't detect retroperitoneal injuries. You can't detect solid organ injuries that are not bleeding into the abdomen. And you can't detect bowel injuries. You have variable sensitivity. You can't always rely on it because there may be a fast bleeder and hasn't had time to bleed into the abdomen, or maybe a slow bleeder and you haven't had time. And single exams may be misleading. So you may exam initially have a sensitivity of 31% and miss the diagnosis. So you should always avoid doing a single FAST exam. You should either do serial FAST exams or a FAST exam and a CT scan. So if there's so many limitations, why do we want to do this? Well, this is a very good trial done by Larry Melniker. It's a randomized controlled trial of blunt abdominal trauma patients. And the average time the OR when ultrasound was in their protocol was 57 minutes. The average time the OR without ultrasound was 166 minutes. Those patients who had an early FAST exam went to the OR 64% faster than those patients without ultrasound exam. So my belief is every patient that comes into the trauma room should have a FAST exam, because if you detect free fluid, you're going to look for injuries quicker, even in the non-hypotensive patient. In those patients you don't find fluid, you still can continue on, but you do know that there's no free intra-abdominal fluid. So here's our algorithm. You get a trauma patient comes in, you do a FAST exam. You find free fluid. The patient's unstable, you need to go to the OR. You find free fluid and the patient's stable, you still need to get a CT scan, but you're probably going to expedite that at this point. And then you're going to deal with whatever injuries you find. If you do a FAST exam and the results are equivocal or negative, you're still going to do a CT. Talk about each one of the views. The right upper quadrant view, here we have an image. We can see the liver, we can see the kidney, we can see a black stripe of fluid that is between the liver and the kidney. This is Morrison's pouch. This is a positive FAST exam. The right upper quadrant is the most likely site to find free intra-abdominal fluid. This is why we start here first. So in the supine patient, Morrison's pouch is the most dependent portion of the abdomen where fluid can collect. About a ½ centimeter stripe correlates to about 500 milliliters of blood. If we look at the markers on the left side of the ultrasound screen, each one of those dots represents a centimeter. So a ½ centimeter, which is about what we're looking at here, correlates to about ½ a liter of blood. A centimeter stripe correlates to about 1 liter of blood. Here's another example. We see the liver and the kidney. There's a rib shadow in our way, but if we look at the anterior or superior portion of the kidney, there's a small, very small, black stripe of fluid anterior to the kidney, between the kidney and the liver. Again, small stripes of fluid are significant. A ½ centimeter stripe of fluid means about ½ a liter of blood. So a small stripe of fluid does not necessarily mean that it's a small amount of blood. It's generally going to be a large amount of blood. Here we see black fluid in the thorax. We assume in the trauma patient this is blood. We can see the hyperechoic stuff in the chest here is actually compressed lung. So the fluid is compressing lung. So this is compressive atelectasis. To the right, we see the dome of the diaphragm and the liver. So all we've done is slide our probe up a couple of interspaces up the ribs, and we can see the chest cavity. Ultrasound can detect about 100 milliliters of blood, so it's very sensitive, more sensitive than a supine chest x-ray. If we look at the inferior pole of the kidney, as we are going to do here, we can see that there's free fluid here. It's actually free fluid in clots. So fluid may not always collect between the liver and the kidney or in Morrison's pouch. It may collect at the inferior pole of the kidney. This is a potential space called the paracolic gutter. This is a fairly rare place for fluid to collect in isolation. However, you will see it on occasion. So to have a good technique, you should pan all the way through Morrison's pouch from right to left, and then look up into the hemothorax and look down at the inferior pole of the kidney. The subxiphoid window, again, we are flat across the abdomen. We're angled up underneath the ribs. We're coming through the liver. And here we see the heart beating, where we notice there's a big stripe of fluid around the heart. Remember, a small amount of fluid in a trauma patient may have a massive hemodynamic effect. So small does not necessarily mean that it's insignificant. Here's a penetrating trauma patient. We can see the heart, we can see the liver. Notice that the stripe of fluid does not look completely hypoechoic. It has small clots of blood in it. It is a bit more difficult to see because it is similar echo texture to the heart and the liver. But if you look, you can see the two structures, the diaphragm and the heart, or the epicardium, and we can see that there's a stripe of fluid between them because they're separated. To determine the significance of a pericardial effusion, look at the IVC. The IVC is a measure of the central venous pressure. As such, if a patient is hypotensive due to volume loss or hypovolemia, their IVC should be small. In the case of a pericardial tamponade, the blood cannot flow into the heart, so the blood will back up into the IVC and dilate. Therefore, we can tell a clinically significant pericardial tamponade by looking at the IVC. In a patient that is hypotensive and has a pericardial effusion, as well as a dilated IVC or elevated central venous pressure, this is the definition of a pericardial tamponade. In the left upper quadrant, fluid most often collects between the spleen and the diaphragm, as we see here. Fluid rarely collects between the spleen and the kidney. So always look at the diaphragm on both sides, but particularly on the left side, not to miss fluid around the spleen. Here's another example. We see massive amount of blood, a large stripe of fluid. We can see this outlining the spleen very well. We see the kidney to the right. We can see this large amount of stripe of fluid between the spleen and the diaphragm. Here's a positive fast exam. We see the bladder. We can see the wall of the bladder outlined because there's fluid on both sides of the bladder. Here's in the cross-sectional view, we see the uterus and with a fluid outlining the bladder wall. This is a positive fast exam. This is a positive pelvic window. So a few pearls and pitfalls. Not all free fluid is blood. So all fluid looks the same on ultrasound. Fluid is black or hypoechoic. We assume in the trauma patient that fluid is blood, but it may be a ruptured bladder and urine in the abdomen. It could be a bleeding ovarian cyst. Again, that's blood, but we don't know, the blood's not coming from the trauma. It could be pre-existing ascites. If you have any doubt as to the character of the fluid, you can do a paracentesis to confirm the identity of the fluid. Remember, it takes time for fluid to accumulate in the abdomen, so serial exams will increase the sensitivity of the fast exam. Be wary of a single fast exam and no other testing. So I suggest always doing serial fast exams before you let the patient go, or a fast exam followed by a CT scan. So what's the diagnosis? Here we have the right upper quadrant view. We see the liver. We see the kidney. Is it positive or is it negative? Well, if you look only in Morrison's pouch, you'll miss the fluid. You have to have a complete technique. And as we slide towards the inferior pole of the kidney, we see that there's a large amount of fluid at the inferior pole of the kidney in the paracolic gutter. Showed this image before. Always slide superior to look at the hemithorax and inferior to look at the inferior pole of the kidney. The isolated fluid in the paracolic gutter is only found in about 2 to 5% of all positive fast exams, so it's fairly rare. So what's the diagnosis here? We have the right upper quadrant window, we have the liver, and we have the kidney. Is it positive or negative? So if you look, there's a very small stripe of fluid between the liver and the kidney. So this is a positive fast exam. The scale, as you can see on the right side, is very small. Each one of these dots represents a centimeter, so this is about a half a centimeter stripe of fluid, and that indicates about 500 milliliters of fluid in the abdomen. Again, a small stripe of fluid is significant. It's a large amount of blood. So in conclusion, the FAST exam is used to evaluate for fluid in the abdomen. This fluid may or may not be blood. In the trauma patient, we assume the fluid to be blood. The FAST exam cannot diagnose retroperitoneal injuries, bowel injuries, or solid organ injuries without intra-abdominal bleeding. A knowledge of these indications and limitations of the FAST exam is essential for appropriate use. Thank you very much.